You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Ryan Walker. In this episode, I'm examining the concept of flash teams with Ben Watts. So what I wanted to do within the concept of flash teams is look at when things are going really well and when things are working. What are some of the core fundamental components of when things are going well? And then look at when things are not going well and what are the fundamental tenets of flash teams when they're not operating well. What we're going to do is examine some of the concepts of issues of ego, lack of team ethos, lack of shared understanding, clear plan, poor communications, name use, active listening, followship and leadership, anchoring, and much more. So to do this, I have Ben Watts with me. Ben is no stranger to the podcast and has spoken on a number of episodes with me, most recently around bleeding and the bleeding patient. So Ben is a critical care retrieval practitioner working in Scotland, and he's also a Royal Extreme Medicine faculty member. Ben, welcome to the podcast.
Hi, Owen. Thanks for having me back. Always nice to have a nice little catch up. Thanks for having me.
So Ben, I wonder if we could just start by looking at what the concept of flash teams means to you.
So flash teams, it's a term that's used synonymously with a few other things. So kind of the instantaneous team, it's this concept of a team of individuals or a team of teams coming together, working together for the first time under stressful situations, under stressful conditions, with limited briefing and preparation time. So it's a team of teams or individuals who are creating this team ethos in a stressful situation towards a common goal. The concept of being in a flash team in the pre-hospital environment, that can be your paramedics, your fire service, your police, all of the different members of the ambulance service, your hazardous area response teams, your HEMS teams, your critical care paramedics, all working together for the interest of patients. We see this at major incidents, we see this at large RTCs, road traffic collisions, and we see it with your cardiac arrest management, where you have a group of clinicians and other members of the emergency services or bystanders coming together to try and do the best thing for the patient. And that has some inherent challenges.
Absolutely. And, some of those challenges, I think you could sort of probably anecdotally speak to, I could too. And we should probably look at that actually. But before we pivot to that, what are some of the fundamental tenets of when things are working well? And I guess that question is more so, how do we orchestrate flash teams in a good way?
So when you have a really high functioning group of individuals working together, you think about your Formula One teams, you think about your football teams, your international rugby teams, you think about your Red Bull cycling teams, or we talk about these high functioning teams that practice all the time, they work together all the time, everyone knows their role, how that role fits in with the other people in their team. How do we achieve that with people that you've never necessarily met before, that you've never worked with before, in a situation where it's not about winning a race, it's not about winning a cup, or this is about making a difference to patients' lives, and without trying to be sensationalist, you're trying to do a very difficult job at times with a group of people who all have differing priorities. So, your police teams and your fire service teams and your ambulance service teams all have slightly different priorities and understandings of situations based on their experience. So when that works really well, what does it feel like? It feels like nobody is working that hard. Generally speaking, you feel like things just go well. It goes easily. Like that was a really what should have been a complicated job, but actually it went well. It felt comfortable. Everyone was communicating really well. In business, they would talk about synergy, right? So this kind of concept of things working at the same time within a system really well, that you get this kind of energy and this buzz, and that stuff just happens in a kind of high functioning way. And it feels effortless. Now, it's not effortless. It's that kind of swan analogy, isn't it? It's the things look amazing, like you've just done an incredible job, but everyone's working hard under the surface. And there's some really key themes when things are going well. And I think it's something that, there are people that are naturally quite good at it. There are people that have to work really hard to be good at it. And there are some people that really struggle to achieve it. And that's, ease of communication. So you talked about some of the things already, but the use of names, the use of closed loop communication, so that asking or giving instructions, asking questions about it, making sure that the person has understood it, or that you've understood what has been asked of you, and then coming back round full circle once that task is done to then confirm that that's happened. When you have a flash team, whether that be your, let's talk about the environment that you and I both most kind of fay with, and that's kind of the pre-hospital emergency medicine or critical care teams, so your EMRS teams. So I work up in Scotland for the Emergency Medical Retrieval Service. I work with a consultant who will be one of 36 odd consultants, and on the helicopter, we have 2 EMRS paramedics. They will vary, but it's a relatively small team. We know each other, okay? We've worked together, we practice together, we train together, we simulate, we debrief together, and we kind of get to know each other really quite well. We know what makes them tick, what makes each other frustrated, the way that we communicate well. Sometimes you can do things without having to communicate because you know what the other person is going to be expecting of you. But then you go and work, on a remote island where I've never met the paramedics, or the fire service, or, whoever's on scene. And you still need to achieve a really high standard. And when you are that kind of critical care service coming in, there's an expectation of how you will act and how you will respond and what you will achieve. And we're not heroes. We're not like these superheroes with capes on. We are hopefully good clinicians, comfortable clinicians who are most importantly focused on the patient. But we can't do what we do in terms of providing anaesthetics and blood and surgical interventions and all of those things unless the fundamentals have been done really well by the crew on scene. We have a great handover, we have good communication with them, we build a good rapport, they have a good rapport with us, they feel they can challenge us, they feel they can say, "Oh, Ben, I'm not comfortable with what you're saying." And that is what makes a good flash team. It's that everybody trying to work together to have as good an experience for the patient as possible. And that means, that nice flow of work between you, that flow of communication.
So listen, that's really important actually, Ben, and that you say that, because interestingly there can be simultaneous activity, but if it's not cohesive, and you said this word earlier, it's this synergy, so that there's this collaboration, and there's good fellowship, fundamentally good fellowship, more so than good leadership, but there is good leadership as well. And because I've been part of scenes before, probably you have too, whereby there is simultaneous activity, so it's not sequential, it's simultaneous, but it's not collaborative. It's not there's no it's not there's no clearly signs of leadership. There's just not that.
You get these independent silos of work, don't you?
Yes.
We all work in our own kind of comfort zones and scope of practice or area of priority. So, we see and feel this on jobs where you have those multi-agency incidents, so where you have the police, the fire service, the ambulance service, Coast Guard, whoever, all working, but without having ease of communication channels. So you're not all on the same radio channel necessarily. Some of the major incidents that you'll attend during your career doesn't always feel joined up. It doesn't always feel like that collaboration is there. And actually, I think, some of the feedback from Manchester and from some of the incidents in London have been around this kind of collaboration and communication. And I think it's really important that, on the small scale, for small incidents where your flash team might be, 2 ambulance crews that have never met before from different stations, who've driven 15 miles in opposite directions to get to a scene, and they're dealing with their first cardiac arrest, say, that is a flash team. That's 4 people who, 2 teams that have never necessarily worked together, who are working towards a common goal. And if they work in collaboration, there's no kind of ego involved of, I'm going to lead this, there may well be the requirement for one person to lead an incident. That may be that there are multiple transitions of leadership during an incident, but that collaboration, that working together is what makes it feel comfortable, and the feeling of it working really nicely and feeling like it has gone well.
So let's look at when it doesn't go well. Let's look at when things start to fall apart, because akin, like you said, it's akin to there being a maestro or and there's people in the band all playing instruments. If they all play their instrument at the same time, it sounds like an absolute mess. But if the maestro is conducting the orchestra so that it's harmonious, and it's in sequence, and it's complementary, then it all starts to flow. But it's not about all playing the same instrument, their instrument at that time. So let's look at when things go wrong, when people are doing simultaneous activity but in the wrong way. How does that feel to you, and what are some of the fundamental components? You mentioned communication. That's a massive piece, actually. Just if you could just name drop a few of the fundamental sort of domains that really need to be steered in the right direction if you're part of a flash team which is going in the wrong direction.
So I think the first thing is a really clear brief. So a shared mental model, a clear plan between agencies, between teams, between individuals, so that you all know what you're actually working towards. If there is one person or one agency that is leading, what is it that they are expecting from everyone else? If I'm turning up as, say, a second or third critical care team on a scene, and it's being led by another critical care team or another critical care service, what do they expect from me? What do they need from me? What do they want? What does the incident commander want? What does the ambulance service incident commander want? What does the fire and police, what are they expecting from us? Are they expecting that we're going to run a casualty clearing station? Are they expecting that we are going to provide an anaesthetic for one patient and take them to a hospital? If we're going in with an expectation of just treating a patient and leaving, but they want us to do something else, that isn't going to work for them. But we're not going to know that unless we've had that conversation. So that shared mental model is really important. I think not having a clear plan is also really difficult. So if actually whoever is leading hasn't got a clear idea of what they need to achieve, and sometimes, I'm sure I've been guilty of this in the past. Sometimes when you are in a position that you are leading and you don't necessarily feel comfortable that you have a full grasp on a situation, you can kind of make a bit of a plan and you kind of communicate that plan a little bit, and people might be a little bit confused about what it is that you're trying to achieve and what you're trying to say. And that's really hard when you're following, particularly if you don't feel you can challenge that person. So, there will be a newly qualified paramedic who's just come out of university or just come out of a, on-the-job training scheme, who arrives at their first big incident, and then the helicopter comes and a second helicopter comes, and you've got all these people walking around that say doctor on the back, or CCP, or advanced retrieval practitioner, or whatever it is. And they might not feel confident to say, guys, and this patient that you're about to anesthetize that's got a blood pressure of 60, should we be doing something about that before we give them an anesthetic? Like, I feel uncomfortable with this, but you guys seem happy, you're just cracking on, and if they don't feel comfortable to be able to challenge you, again, you're failing your patient, aren't you? So, and you're not going to have that synergy, that collaboration. So I think being able to be challenged, being approachable, and giving people that opportunity, particularly when you are a senior clinician on scene, or you're, in a position of leadership, and particularly if there is that lack of clear plan, chaotic scenes. We've all been there. A job that is just mad. Like, you couldn't write it. People, if you put it on TV, people would be like, that's ridiculous, that would never happen. And you're like, this is actually happening. It's just, there's everything is on fire, everyone's on a tightrope, everyone's going to fall off. It's just utter chaos. And those scenes, like, that is really difficult to try and have a clear plan, communicate, collaborate. So for example, when you've got, say, football violence or large riot or something like that, where you've got hundreds or thousands of people in a small space with an undefined scene. So it's not just, this is where we are, this is the two cars that have crashed and we're dealing with that. There's stuff going on in different places, there's different channels of communication that are happening between different teams, and the information you're being fed is third or fourth hand. You're trying to pass information to the police, and that's being misunderstood or miscommunicated, or the information that you've been passed by ambulance control is actually stuff that was originally passed from by the police, and now you're passing it back to the police. And as a clinician, we may have an idea in our head. So Owen and I go to a job together, and it may be a slightly split scene or whatever it is, but we have a clear plan in our head. Those plans may look completely different from each other. The competing priorities that we see, if you don't have a conversation about that, you're going to be working towards different things. And so when I say to Owen, oh, this patient needs a sedation and they need their femur pulled and they need this and that, and you're like, yeah, but this guy he's got a time critical injury to his ankle, and I'm like, okay, yeah, but this guy's femur, and you don't actually listen to each other because you're so absorbed into your own kind of dialogue of what's happening in front of you, and you've got this kind of view of what needs to happen. Or when you're on your way to a job, you're in the ambulance, you're in the car, helicopter, whatever, and you're told some information. So the classic is you're going to a 2-car RTC with 3 patients, 1 P1 and 2 P2s. First ambulance crews arrived on scene, asked for HEMS. And you're going and you're like, right, cool, there's 3 patients, 1 P1, 2 P2s. We'll have a look at the P1 first, see what they need, and then one of us or both of us will go and have a quick look at the P2, just make sure that we're not missing anything, and we'll come back together. And you get there and there's 3 cars, because one was in a ditch that no one had noticed initially. You've seen it as you're coming into land, but why would anyone have seen it? Because it's down a massive ditch behind a load of bushes that no one could see. And suddenly your mental model is not what you found, but you potentially will anchor on certain things that people tell you. Oh, this person has a pelvic injury, so that to you that was their major concern. You go and look at them, you're like, yes, they have a pelvic injury, so that's what I'm going to treat. But actually you miss the big chest injury that they have. Or if you just focus on those little things that people have said, as a team you can fall apart. As an individual you can get task focus. You can, you look at the classic example. So the Elaine Bromley case, right? So lots of people working together, they know each other, a lot of them. There's a few people coming in, the communication is difficult, there's a big command gradient, and they weren't working in a collaborative way, despite the fact that they were trying to work in a collaborative way. You know, there were multiple people working very hard to try and manage Elaine Bromley's airway, but then you think about the kind of the nurses and HCAs, the ODPs, the surgical scrub nurses, who all had an idea in their head, but that communication, although it happened, didn't happen in a way that people were listening. The collaboration wasn't there. The synergy that you may expect didn't happen for various different reasons. You know, that task focus, that focusing on one element of the whole picture. So sharing that mental model, communicating, making a clear plan, listening, really listening to what is being said, and then really clear communication, closing the loop of that communication, making sure that what you have said has been received and understood, and that what you have said is what you meant to say.
There's a lot in that, actually, Ben, and you make some fantastic points. And one of the points you're making, which I really appreciate, is it doesn't take much for people's mental bucket to fill. And actually, and you're right, once it's full, there's the entropy, the information entropy and the decision-making entropy starts to occur quite quickly. And so if you're not, as a leader, able to pivot, delegate, and really focus on the noise versus, sorry, on the signal versus noise, on the true priorities on the scene, then if you're not able to do that, then you will become, the overwhelm will reach you in a matter of minutes. And another thing you said, which is really interesting, is and we used to do this in simulation, is instead of having just one or two practitioners or assistants to help you in a scene, if you flood a simulation with 5, 6, 7, 8, 9, 10 people, all willing, all able, it soon becomes ultimately extremely chaotic unless you grip that scene quite quickly. So you delegate tasks, you use names, you use eye contact, closed loop communication. But interestingly, it's almost more difficult when you have too many resources versus when you don't have enough resources, because there's just the sense of collective altruism. People want to do good, but and it's the malaise starts to really set in. But so and both of those are really interesting. But Ben, I want to sort of pivot and look at this concept of sort of feedback channels, because we have mentioned, you know, the brass tacks of good communication is fundamental throughout the scene, and like you said, active listening is so actually easy to say, really hard to do. But what could you speak to feedback channels from Flash teams? Of what are some of the maybe more optimal feedback channels or feedback mechanisms that foster learning, that foster better Flash teams over time? You mentioned the brief, and I think the brief is a great initial mechanism for passage of information. What else is good from a feedback perspective?
So I guess if you split this down into kind of three main feedback mechanisms, really. So you've got the on-scene feedback. Okay, so you've got the whilst the job is going on, that was great, you're doing an amazing job, you're doing really well, I know this is uncomfortable for you, this is uncomfortable for me, this is a challenging job. Giving people that positive affirmation, making it okay that they are finding something, potentially emotionally challenging, cognitively challenging, that is really powerful. So when you're on scene, talking to people, explaining what they're doing is the right thing. If there are things that need to be done differently or slightly optimized, giving them small hints. You're doing great, but let's have a think about, could you do this? Can we just slow down the ventilation? Could we, giving people that information in a way that doesn't degrade them, doesn't make them feel like they're doing a bad job, because they're not. They're doing an amazing job in a stressful situation. So that first kind of feedback is that on-scene feedback, so live feedback as you're going, and kind of giving people that constant both reassurance, direction, specific instruction. That's important. Asking, am I missing anything? What am I not seeing? Can anyone see anything that we're missing? Has anyone got any thoughts about anything else that we need to be doing for this patient, this scene? That feedback is in both directions. The second is that kind of hot debrief. So that's the immediate after action. What has happened? What have we done? Does anyone have any immediate concerns that we need to address now? And then, if it's available and if it's required, that slow time feedback. So either, this can happen in a few different ways. So I will try and give most people that I travel to hospital with, most of the crew that I travel with, I'll give them my email or the contact number for the base, so that they can phone up and they can ask for some feedback about their patient. I always say, if you have any questions or you think of anything, or you've got something that just is really niggling you, just get in contact. We can have a chat about it. And in some circumstances, having that cold debrief, that slow time, full dissection of an incident. I was involved in a major incident recently where we had a good, I think it was probably about an hour and a half. Sadly, I got interrupted to go on a job from the debrief. But having that opportunity to have a cold debrief, a slow time, look at a job, the nuts and bolts of it, what went well, what we learned, what we thought about, what would we do differently next, and as part of that, having a little bit of emotional awareness about the incident. And I will always say to people after a traumatic incident or a really challenging job, particularly to people who've not experienced them before, or to people that have children that are young, and we've just been to a young pediatric job, and I can see that they're already making little associations in their head. That's normal. That is normal. That's normal to have those feelings. It's normal to have that conversation. And I'll say to people, it is normal to think about this. It might be normal to have some dreams about it. It might be normal that you'll be driving past somewhere and it'll trigger something in your mind. What's not normal is for that to keep going on and that to keep happening. So if that does happen, you have any concerns, in the next 48, 72 hours or in a few weeks' time, just get in contact with your wellbeing services, whatever you have available. If you need to speak to one of us from the team, phone up the base, drop me an email, and that is kind of your third feedback. And that kind of covers quite a lot of things. So that's your slow time individual feedback, your patient feedback. So what's happened to the patient, what injuries were found, if you're able to get the post-mortem data, if the patient has died, things like that. That's all really valid feedback. And that all plays into that team dynamic for future. The fact that you've met and worked with people, I've been in Scotland for a couple of years now, and I start to know some of the crews, and you meet people and go, oh, how are you doing? We did that job together. Oh yeah, and we did that job. And, and immediately you've got a bit of a dynamic, and that's great, because that gives the scene some energy. That gives, other people will see that relationship between, even if it's just two of you on scene that have worked together before, that relationship is infective. If there is a positive relationship on scene, that is infective. People will be like, oh, cool, I can get on board with this. There's a bit of a dynamic here and we can work really well together. And equally, that also happens in a negative way. So if you turn up and someone's like, oh, it's Ben, bloody hell, like I've worked with him, he's really hard work, like had such a bad job with him and he was really bad, blah, blah, blah. Like just like that kind of negative energy just will sap a scene. Like, it'll sap the scene of momentum, it will sap the scene of collaboration. Fire service and police, like if you've had a bad incident with a fire commander, you're working on the job together again, and they're like, oh, it's a bloody HEMS team have turned up, and it doesn't even have to have been you, it's just someone else in a red suit that they've had a negative experience of, or an ambulance crew that they've just done a job with the ambulance crew and they were a little bit rude because they were like 7 hours late, and then suddenly the fire service are now at a different job with a different ambulance crew, but they're like, oh, that ambulance crew was really rude to us, so now we're annoyed with ambulance service. We're all human, we're all capable of doing that. If we're hungry, if we're tired, if we're running late, so you haven't finished your shift and we're due to finish 4 hours ago, like that's going to affect you. We've all got stuff going on at home, we've all got families or friends that we're meant to be seeing, or clubs that we're meant to be at, or whatever it might be, or just you have plans to go to the gym, or you wanted to watch EastEnders or the football match or whatever's going on. That will affect you, and it'll affect everything else on scene. And having a little bit of awareness of what triggers you, awareness of the effect it has on other people, and the effect it can have on your patient is really, really important. So managing those negative dynamics can have such a positive impact on a scene. As soon as you see it in someone else, try and build that positive domain, try and build that positive relationship. It's difficult to explain the way that negative can be turned to positive really quickly. When you see it happen and when you see it done well, that it's such a powerful tool. An example of this was a doctor that I was working with. It was a complex trauma patient who was a complex trauma on the back of what appeared to be a bit of an acute behavioural disturbance. And there were some negative dynamics between the fire service, the ambulance service. I'm not sure what was particularly triggering it. And actually what needed to happen was it just needed to be challenged. And it just needed to be, guys, like, there's something's going on here. I'm not happy with this. We need to work together. This is all about the patient. Can we just, everyone come together, 2 people stay with the patient, make sure that nothing changes, keep giving him some medication, giving him some reassurance. We need to have a chat. Let's just make sure we're all on the same page. This is what we are doing, why we're doing it, how we're doing it. This is what we want to achieve. This is what we want for the patient, and this is what we want from you. What do you need from us? And having that conversation, and suddenly everyone's really energized and engaged because they now understand what we're trying to achieve and what they want and what everyone needs to happen for this patient from the different services. And suddenly the whole dynamic of the scene changes. And it's amazing, like the way that you can invigorate your team just by changing the narrative on scene. It's such a powerful tool.
Yeah, absolutely. And like you said, just asking, what can we do to help you, or how can we support you? It's almost a nice way, even in a really difficult, challenging, stressful environment, of kind of offering that support, and ultimately offering to kind of really, just supplement care, but not trying to take over, not trying to, and doing it in a way whereby it's not an ego play. Essentially, we're all here for the patient, as you were saying. Ben, looking at what I want to do is just really look at, so there is a concept within Flash Teams, and you can probably speak to this, as can I, but it's around this concept of stun, and so incremental stress, and it gets to a place of overwhelm where there's just this stunning, and the amygdala is truly firing. I'm talking about in the staff here, so that there is that really horrendous pediatric cardiac arrest, or that there's multiple patients all being shot at the same time, and there's just feels overwhelming. The classic case of the major incident, or there's a boat on its side in somewhere in Scotland. So how do you navigate and or deal with people that are just absolutely stunned. Their amygdala is truly firing. They've got this fight or flight. They can't move. They can't really do much. And it's either progressive or it's a full on impact. How do you navigate those kind of dynamics?
So I think when you're looking at these kind of dynamics, that people get stunned for a number of different reasons. They get stunned, or they kind of have that startle effect because something has happened that they weren't expecting, whether that be the situation generally, or whether that be something has happened on scene, something's changed. When people are truly maxed out by something, their cognitive bandwidth, their ability to think and speak coherently has been so overwhelmed, they just need a little bit of a step back. I think it was possibly Neil Jeffers, the London HEMS pilot, that in one of his talks that I listened to once, he was talking about a doctor who was on scene, and he could just see that this doctor had become overwhelmed and not quite, wasn't functioning to their normal, really high standard. This person was a really high functioning individual, and Neil talks about just going over and just putting his hand on their shoulder and being like, "Do you need to go and stand over there for 2 minutes?" And the doctor was like, yes, I do. And walked away from the scene, had a little minute just gathering their thoughts, came back and was like, right, we've got a plan. This is what we need to do. This is what we need to achieve. And has that kind of really like positive effect for that person. They just become saturated, but then removing themselves slightly from that scene to have, I think, possibly a conversation with someone. You might phone a friend if you're in a position where you've got senior advice, or you've got a team leader you can speak to, or other people on scene. Having that moment to step away gives people a really good opportunity to kind of stop that kind of cycle of I'm overwhelmed, what should I do? I've been to jobs where you turn up on scene and there's just no momentum. Like there's nothing quite happening on scene, and it's not because the people on scene are bad clinicians. It's not because they don't care. It's because they just don't know what to do, because they're saturated. It's a really graphic scene, or it's something that is a very rare presentation, or they just don't feel confident or comfortable with the interventions that need to be done, or the steps to get to the point where they can do interventions. And having that step back, having that moment to say, what do I need to be able to do to control my own physiology here? What do I need to be able to do to control my own cognitive load so that I can be of maximum benefit to my patient? When you do feel that maxed out moment of, I don't know what to do or say, or I don't know what direction this needs to go in, it's really difficult to self kind of manage that. It's really difficult to self-rescue. But when you start to understand what triggers you, what maxes you out, and also if anyone ever gives you feedback of, oh, you became quite quiet there, or you appeared to just kind of freeze for a little while and not really do anything. Like, if people give you that feedback, think, what was I thinking at the time? What was going through my head? What was I doing? What had got me to the point of inaction? Sometimes just finding a small task that just gives you a moment to think, whether that be, I don't know, going to get the trolley, right? It's a simple job that quite often gets overlooked, and people will think, oh, anyone can get the trolley, but whoever needs to get a trolley can get a trolley. Like, if I I'm the only person that's not in the middle of doing a job, I'll quite happily go and get a trolley out of the back of an ambulance and wheel it up to scene. And whilst I'm doing that, I'll be looking at the scene. I'll be thinking, what else do I need to do? What needs to be done? And it's not wasted time. It's not a waste of my time as a advanced practitioner. That's a job that actually I might choose to go and do to give myself a little bit of thinking space if I'm becoming overwhelmed by something. Equally, it might be because there's nothing else that needs to be done by me, and therefore everyone else is doing their job really well. When it comes to that startle, that freeze, that kind of moment of you can see it sometimes on people's faces, that kind of deer in the headlights. Their eyes become wider. They might have the hands that just come up and don't do anything, that they just kind of are stood really still, but with their hands in awkward positions because they're trying to work out what to do, or they might be fiddling with something, or just holding a piece of equipment that doesn't necessarily need to be held, but they're trying to self-regulate that significant overload of emotion and cognitive kind of processing. And if you as a clinician are turning up on scene, you can do a lot to help manage that. If you're in a position that you are becoming overloaded, or your colleague is becoming overloaded, or you turn up to a scene and everyone appears to be overloaded, coming in and being that calm, being that person who maybe takes a little bit of a step back and becomes that kind of lighthouse leader, that that stationary person who actually can just give a little bit of direction and guide people through that fog of that chaos, that startle, that whatever it may be, that inaction due to a lack of real kind of, not that people don't know what to do, but that they just don't feel comfortable doing what they know that they need to do, or they're not quite sure of what order to do things in. When there are so many tasks to achieve and you get to that point of saturation, I know that we've talked about jobs where this has happened for both of us, both to us and to other people, but where you just have so many jobs that need done. Now, where do you start? And then you just don't do anything for a period of time because you're trying to work out what to do, and all you needed to do was just do one of the jobs, any of them, and it would have started the momentum.
No, listen, I agree. And just to your point, Ben, around keeping tasks, when you see someone who's startled and or maxed out, just keeping tasks simple, keeping the cadence of communication slow, tonality, intonation, slowing it down, calling them by name. Just, could you get me this, or can we do this, or let's do that together, or this. But it has to be simple, because like I said, they've got no capacity for complex motor skills, no capacity for simultaneous activity, or indeed dynamic thinking or decision making. It's simple task acquisition. It's name, it's let's just get this, let's do that, and giving them a chance to get back in the game, get back into the mindset.
Absolutely, that it is that moment of the chief pilot, Neil Jeffers, coming over and touching someone on the elbow or the shoulder and just saying, "Do you need a minute?" It is that little simple act, isn't it? It's the, like you say, giving someone a specific task, very clear instruction in a kind, supportive way, will guide them into reducing that cognitive load. That is certainly what I need. So if anyone ever sees me looking maxed out, just give me a prod on the shoulder and say, "Ben, can you go and get the stretcher?"
One thing I really like you said, and I learned this a while ago from a fantastic clinician myself, is around almost this deferred decision making, where because if you're leading a scene and or you're driving a scene forward, but you still don't know truly what's killing a patient, because it is complex, there's maybe a mixed medical and trauma pathology, but just so this deferred decision making is around, right, guys, can we package the patient, can we put them on the trolley bed, can we get them to the entrance of the ambulance? And what it is they were going to do that anyway. People were going to, clinicians were going to do that anyway, but it's almost giving them, like you said, a clear plan. It's a simple plan, but what that's doing is buying you time to put your assessment together with a few more blood pressures, maybe a few more pulse points, a few more just markers where you can start to piece together what the cohesive plan is. And again, people, the absence of a plan slows the scene down. But even if it's not a complex plan, right, guys, can we package patient in 2 minutes? 2 minutes. Can we have this patient at the back of the ambulance, and we're going to reassess? And again, you've not kind of done. You've stipulated a forward thinking. The acquisition of something of a future request of 2 minutes. We need to be here, but it gives you that 2 minutes just to really start to drill down, right? What do I need to do in a sequential fashion, or what do I need to delegate? And again, it's the appearance of leadership without truly making a definitive decision.
I really like that. It's something that I think unconsciously we do a lot. Consciously, we don't use it as often as we could. I think it's something that sometimes actually I think we're a little bit afraid to do, to say we don't currently know what our plan is, but we know that we're moving in the direction of hospital, and therefore let's start that process whilst we make a decision. A really good example of this actually was a nasty neck stabbing that I went to with a really, really good doctor. And the guy was really agitated, but he was agitated for multiple reasons. He's hypovolemic, he's probably a bit hypoxic, he's in pain, and he's also agitated through probably some illicit substances, and he's been stabbed. So he's not happy. Like, this guy is agitated from a number of different reasons. And I think the scene that we were on was very chaotic. There was a lot of people. It wasn't quite at the point of being controlled by the police yet, and there was just a lot going on. We just got the patient was already in an ambulance, so the ambulance crew were like, right, can we just start driving towards the hospital? We're going to have a decent assessment of this patient, but we just don't need to be here right now. And once we'd given this patient a really good assessment, we'd assessed his wounds, we'd got good wound packing, we realised that this patient actually had an expanding haematoma and was really uncomfortable, had lots of pain. We gave him lots of ketamine, became less agitated, but actually we realised that hemodynamically he was relatively unstable once we'd managed to get some monitoring on him. And this guy needed blood, and he needed an anaesthetic, and there was lots of things he actually needed, as well as getting to definitive point of care. And so that little moment of just driving away from scene, although that was putting some physical distance between ourselves and a lot of chaos, it also just gave us that little bit of headspace to make a plan. But it was the right thing for the patient at the time, and the wrong thing for the patient at the time was staying on scene to make those decisions, because there was so much chaos going on that was further agitating the patient as well. It's a really underutilized tool of those kind of delayed decision points. So I think I did a fairly informal kind of Google Polls, Google form type survey a little while ago, just put it out on Twitter, and had 110 responses. So, a lot of people, and it's really interesting. There were some really and it was looking at flash teams and kind of the human factor dynamics around working in a flash team. And what was really interesting was that out of those 110 people, 43% had regular training in non-technical skills, right? So that's 43%. Now, to the people that are listening, this is probably a self-selecting group of people that responded to this survey. And I would imagine that regular training is not actually available to 43% of clinicians around non-technical skills. One-off training, 36%. That, again, that's really interesting. The number of people who have some training in this, but once, and then 21% have never had non-technical skills training, human factors training, CRM training. And so having some awareness of these themes that run through the team dynamics is so valuable to to the people on scene. So if when you are debriefing, you can focus on some of those non-technical skills as well as the technical skills, it just really strengthens that development of the team dynamic and the team collaboration. Particularly, if you think about the police service and the fire service, I can't remember the name of the fire commander who is it Sabrina Hatton-Cohen, who's done lots of work around human factors within the fire service, and she's done some incredible work around developing some CRM training and human factors training for the fire service, and we can all learn from that. We as an ambulance kind of profession are a long way behind our anaesthetic colleagues, who are a long way behind the aviation industry, and we can all learn from each other in these scenarios. When you have a multi-agency debrief, non-technical skills, it just isn't a key point for your debrief. It's all about what happened, what did we do. It's not how did it work, how did it feel, what was the communication like, did anyone piss each other off, what did you do, how did you talk to people that actually meant they felt that they were part of that team and that they were being supported, and how did they feel that you were facilitating them to do the best thing for the patient. And I think the opportunity to look at the non-technical skills, look at the human factors, look at the crew resource management, both long-term from a training point of view, individually from understanding some of the theory and the practical concepts of that theory, practicing non-technical skills. So, non-clinical scenarios where actually you're just training your ability to focus on multiple tasks, to use a checklist for a non-technical reason in a difficult situation where there's lots of noise or the environment is challenging or whatever it may be. But we don't get that opportunity, as certainly not as a paramedic on the road. That opportunity is just not there as often as we would like. We in our critical care teams, our HEMS teams, we're really fortunate that we can simulate most days. We can do simulation training, we can do some form of clinical governance debrief for most jobs that we go to. Not all of our colleagues are fortunate enough to have that available to them, and obviously they'll chat jobs through when they're on the truck with their crewmate, but that's not necessarily the same as having a semi-structured debrief and having that supportive environment where we can all learn and we can challenge each other and we can ask questions. I always say that there's no such thing as a stupid question. There might be a question that you want to ask on a one-on-one basis rather than in front of a large group of people because you feel it's a stupid question. It doesn't mean it is a stupid question, but you might feel more comfortable asking it in a smaller group environment or on a one-on-one. But if you don't ask those questions, you never will find out the answers, or more importantly, you think you know the answer but you're not sure, you can't check. And I think it's really valuable to ask those questions, to have that opportunity. And so certainly as senior clinicians within the ambulance service, within HEMS services, facilitating that to your ambulance crews, to your police, your fire service, when the fire service say, why did you do that? What did you do? How did you do it? Give them that opportunity.
So a couple of things just before we come into land, Ben, just a couple more questions really. One is around how you train, how should you train for flash teams to create the chaos, to almost elicit those non-technical skills. We've spoken before about the concept of forced failure, forcing failure on clinicians to mimic reality. Whatever you do doesn't work. Whatever treatment pathway you go down, this patient's still dying in front of you. And we've talked about this concept of overwhelm, flooding a simulation with loads of people just to see what happens, because it is fundamentally really difficult when there's more resources rather than less. And we've also talked about this, this concept of the unhelpful leader. So you get to a scene and there's already someone on scene who's trying to lead, but they're maybe flailing, they're maybe failing, in their leadership, but they want to be seen to lead. They're trying to lead, and and how how a simulation works in that sense, because again, that's a very challenging, non-technical scene. But from your perspective, what are some of the concepts that services could elicit, or indeed create, to give rise to challenging flash teams, so that when they're in practice, they're suitably equipped?
So I think I should probably start this with an apology to anyone that Owen and I have ever worked together to sim or run scenarios for, because this is something that we enjoy a lot. Anyone who has ever been involved in a simulation with us will understand what I'm saying there. It's really valuable to understand that failure in sim is okay, but that also potentially has some emotional impact on that person. It's important that any sim to failure, and what I mean by sim to failure is, you go to someone who's fallen off a bridge and you miss your cannulas and you miss, there are lots of things to try and trick you, or to kind of throw you off. And so you're not ventilating with the eye gel, you decompress the chest and it hasn't done anything, there's no air release, there's your patient still isn't oxygenating, or making every single intervention unsuccessful, the equipment breaks, stuff like that just will add pressure and stress. Changing the environment, so simulating in a classroom, it's just not, it's not what you need. You need to be simulating outside in inclement weather, in the dark, using only head torches, somewhere where there's no artificial light. Have speakers playing death metal or gunfire or dogs barking, or whatever it may be, that is just there, that hectic club music that's just pumping in the background, having a strobe light on, things like that just overwhelm the senses. And these are things that you can achieve with no real expenditure. It doesn't have to be expensive and flashy in the sense of lots of equipment, lots of extra things to make. This can be, you put headphones on everyone from that they already have and get them to play music on their phone, and then try and communicate an intervention or run a cardiac arrest whilst everyone has headphones on. You're simulating that noisy environment. Get everyone to listen to a Spotify playlist of building yard sounds or whatever it may be. Turn the lights off in the ambulance like parking bay or whatever it may be. Do whatever you can to just overwhelm the senses and add challenge. If there are multiple people available, brief them to be difficult, brief them that they don't understand things, everything that you ask them to do that you think that person should be able to do. I'm really sorry, but I don't understand what you mean, because that ability to then change the way that you say something, to change the way that you are giving instruction, that overwhelms people's senses, overwhelms their cognitive load, and you can quickly tip people into the point of saturation. Doing training at 3:00 in the afternoon on a Wednesday every week, that's great, that's lovely. Do some training at 3 a.m. That's not something that's available to most people. But if you are on the night shift on an ambulance station where you do get time occasionally on base with a couple of other crews, be like, right, it's 3 a.m, let's go and do a sim in the car park. Like, your colleagues will hate you already, they're on the back foot. But that is the realism of the job that we do, and that is powerful.
So as you're coming to land, Ben, I fundamentally agree with everything you just said. Actually, I think it truly is mimicking reality as close and aligning it as close as you can, so that there's just these healthy analogs in your mind that you can just call on when reality does start to impinge. But just take home messages. If there were just 2 or 3 take home messages, Ben, around Flash teams and how to orchestrate optimal Flash teams, what would they be?
So it is patient-centered. It's not rocket science. This is about teams, not heroes, not individuals. Try and view your own leadership through someone else's eyes. Have a bag of tricks available to you. Closed loop communication, share your mental model, take 10 seconds for the next 10 minutes, whatever it may be, have a bag of tricks. Be that lighthouse, not the fog. Be open to ideas, be open to criticism at the time and afterwards, learn from that. Being part of a team does not mean you have to lead, particularly from a HEMS point of view as a critical care paramedic, as a doctor. Being part of a team is about being a part of a team where you need to be. Debrief where you can. That is a powerful opportunity that is underutilized. And remember that some of these things are rare events for people. You are not seeing significant traumatic cardiac arrests every day as a paramedic on the road on an ambulance in a rural area. You're not seeing maternal cardiac arrests regularly. You're not seeing major incidents regularly. These are rare events. Give people a bit of slack. Don't expect them to perform as well as they might in these situations that they may never have seen before. Be kind.
Ben, thank you. That was fantastic, and that's some really fantastic points there, actually, that we can all learn from. Thank you for your time over this last hour, Ben.
Cheers, Owen. Have a good one, mate.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.